So I'm here with Dr. Jennifer Sweeton. Dr. Sweeton is a licensed clinical psychologist, best-selling author, internationally recognized expert on trauma, anxiety, women's issues, and the neuroscience of mental health. Dr. Sweeton completed her doctoral training at the Stanford University School of Medicine, as well as a master's degree in affective neuroscience from Stanford. She studied behavioral genetics at Harvard University. Thank you, Dr. Sweeton, for taking the time out of your busy schedule.
Thank you so much for having me.
Now, Dr. Sweeton, we have you scheduled to present at our upcoming Trauma and Addiction Conference taking place in Edmonton, and we're co-sponsoring that with the Sunshine Coast Health Center. And we also have you scheduled to provide a 3-day intensive on EMDR held in Calgary during the month of July of this year. So I have a few questions to ask you that relate to your training. So in order to begin, can you identify several key brain structures involved in addiction and PTSD?
Absolutely. So I could go on about this for a long time, but kind of the cool thing about the brain is that it's the same areas that tend to be involved actually throughout a lot of different mental health conditions. So the main ones that we're going to be looking at are the amygdala, so that threat detection center of the brain that we know gets too activated in PTSD. Another one that we'll be looking at is the hippocampus, which is the long-term memory storage unit of the brain, which we know can get underactive and atrophied in PTSD and also with chronic addiction. Another area of the brain that can be impacted by both addiction and trauma is going to be this area called the insula, which is the area of the brain that allows you to feel into internal experiences. So when that area of the brain gets underactive, people aren't really sure how they feel, and they tend to miss the early signs of triggers for relapse and addiction. So that plays a role in both trauma and addiction. And then we have these top areas of the brain, a little bit higher up, these more cortical structures we think of as the more rational or logical areas of the brain, such as the cingulate or the prefrontal cortex, which is like right here. And they're more involved in rational thinking, conflict monitoring, emotion regulation, thought regulation. And we know that with both trauma and addiction, those areas shut down quite a bit. And with addiction can actually begin to atrophy. So it makes it hard to think clearly and make good decisions. So what you get with both trauma and addiction is this brain where some of the lower areas like that threat center become very activated and dominate brain functioning, whereas some of these top areas that you really want online that allow you to make good decisions and think through things, they become more shut down. So one of the things that I like to talk about in my workshops is how you begin to reverse that, to have a little bit more of a top-heavy brain.
Okay, excellent. You're going to cover a lot of information at the conference.
Yes, I hope to.
Yeah. So can you describe how developmental trauma brain change differs from brain change observed in adulthood trauma?
Yeah, absolutely. So, this is a big topic. Sometimes I spend entire days just talking about this. The areas of the brain that are impacted with developmental trauma versus adulthood trauma, it's about the same. So it's still, the prefrontal cortex, cingulate, insula, hippocampus, amygdala. Don't worry if you can't memorize it that quickly. It's the same areas, but you can think of it kind of like this. With developmental trauma, you might see more pervasive or more severe deficits as a result of damage to these structures or ways that they're developing a little bit differently. So I don't like to make people too nervous at the outset, thinking, oh my gosh, there's no way we can reverse this, because absolutely we can treat this. But you might see more severe deficits, for instance, in an area like the amygdala, that threat detection center of the brain, where if you're traumatized for the first time when you're an adult, the amygdala is fully developed, but most importantly, it's also pruned, meaning it's not as active as it was when you were a 2-year-old if you've had healthy, non-abusive development, because those neurons have pruned over time. It's kind of like the brain recognized that it didn't need to be that hyperactive to keep you safe. So your brain starts to match the development. So if you have a trauma for the first time at the age of 40 and you had nothing before then, you have a pretty calm amygdala. And yeah, absolutely, that trauma can disrupt that activation where now it's more active than it needs to be. But that's very different than trauma that would happen very early in life where the amygdala never prunes. So it never even gets the chance to kind of calm that activation down. So that's an example of the type of deficit that we might see. But we also see deficits in other brain areas. Brain connectivity is going to be impacted. We see that with developmental trauma, there's a lot of impacts, we think, or a lot of correlations, at least, with deficits in the prefrontal cortex, people not being really sure of what their identity is, who they are, not focusing as well. Sometimes that gets diagnosed even as ADHD, trouble connecting with others, and a lot of things like that. So there can be a lot of potential deficits, but again, I think there's a lot of hope for treatment.
Okay, excellent. Can you provide several examples of several brain-changing techniques that reduce trauma and addiction symptoms?
Yeah. So when I think about techniques for addiction and for trauma, a lot of these are going to be overlapping techniques, which is great. I like to separate it into two main categories. So techniques where you're working through the body to change the brain, especially the lower areas. Okay, hypothalamus, thalamus, amygdala. Kind of think of it from here down. 4 areas of the brain that are impacted, these top areas, with what we call top-down techniques. So top-down techniques are when you're using your mind or your thoughts to change the brain. So historically, psychotherapy has been very top-down, where you're using talk therapy or thoughts or your mind to change the brain. But we know we can also change the brain through the body because the body is literally physically connected to the brain. So we know, for instance, that some bottom-up techniques like breath work can activate through the body something called the vagus nerve and send a relaxation signal up to the brain that then begins to chip away at the activation of the amygdala and some surrounding structures. So you can work through the body to calm some of those lower areas of the brain. And we know then also that cognitive techniques, or how we use our mind, can be used to strengthen these areas. And if we get a really strong brain, we can actually use our mind to down-regulate the amygdala, though that does take training. So techniques that could be examples. Bottom up might be grounding techniques, might be sensory awareness techniques. It might be movement-based stuff like yoga. It could be breath work or other body-based work such as body scanning, autogenic training, progressive muscle relaxation. And the top-down ones would be more, again, your cognitive techniques. So your cognitive restructuring or reframing, a lot of your more intensive meditations can also fall into that category. And then you have these therapies such as EMDR, which are hybrids. They're bottom up and they're top down, all put together.
Excellent. And I know in our workshop evaluations, participants always comment on the strategies and techniques they're looking for from the training. And I reviewed your outlines, and they're packed with a lot of strategies and techniques that you will be talking about and demonstrating.
Absolutely. Yes. I like to leave workshops where I leave a lot behind in terms of the techniques you can begin using. So the great thing about these brain areas that we're trying to target is that we can change them. And we do know the types of techniques that change those in the direction of health.
Excellent. Now, before introducing EMDR techniques with clients, how do you determine which clients should use EMDR?
Yeah, I think this is a point of debate. It can be somewhat of a controversial topic. I would say, first of all, clients need to want to. Okay, so we can talk a little bit about what you can provide in terms of psychoeducation to clients. But of course, we know that we don't ever want to be coercive. Trauma is all about being out of control and too much, too fast, and the stuff that we don't want. So always getting that permission and consent. Beyond that, few things to consider. So one is that you may not want to use this with active psychosis, not a lot of great evidence for it. You want to keep in mind that EMDR, what it's evidence-based for, the one thing it's really the best for is trauma, although we know modifications make it so that we can use it with a variety of different conditions. It's really best with trauma, according to the research at this point. In terms of other thoughts about who to not use it with, if you're working with a client who has a history of seizures, you're probably going to want to watch using a light bar, flashing lights if you have a history of seizures. May not want to use eye movements at all. Also, if you have a client who's in litigation, you might want to consider maybe a different exposure-based therapy, or if that piece can wait just a little bit, although I hesitate to say that because I always want to do what's best for the mental health of my clients.
Right.
not a litigation case. But the thing to consider about that is sometimes through the reprocessing, through the memory reconsolidation of EMDR, stories will change. And it's not because people are not telling the truth, but because through memory consolidation, sometimes those fragmented memories start to get put together. And that's what we want, is an integrated brain. But they might be accused of, changing their story, or they might not look as distressed on the stand when they're put on the stand because they've changed that emotional relationship to the memory. But I'd say, honestly, it can be used with a wide variety of clients, modifications even for children, and it has a great evidence base behind it.
Yeah, excellent. Now, one final question. Can you explain the differences between EMDR strategies recommended for trauma and EMDR strategies recommended for anxiety?
Yes. So I might oversimplify this just a little bit, but the way to think about this is that anxiety is more future-based and trauma is past-based. So when you're doing EMDR for trauma, you're going to focus on something that actually happened in the past, whereas EMDR for anxiety is focusing on something that's anticipated in the future, but that has not happened. So sometimes when people get stuck on this is they'll say, well, in classic EMDR, you're supposed to bring to mind an image of the worst moment of something. But if it's anxiety and it's not based on a past traumatic event, there is no image of something that happened. The answer to that is with anxiety and EMDR, they're going to come up with an image of the worst possible scenario that they can imagine. And it actually doesn't matter that it's never happened, because if you have a fear of something, I guarantee you that you have a neural network for it. And the idea with EMDR is shifting these neural networks to where they're less distressing. So even if you've never been in a plane crash, if you fear it, it's still in your brain. And that network is still getting activated and causing you distress. So we can use it for these future anticipated events in a very similar way, actually, to how we do it with past events.
Excellent. Now, just to wrap up this Skype interview, Dr. Sweeton will be providing a full-day workshop at our upcoming Trauma and Addiction Conference held in Edmonton on May 28th this spring, and we'll be providing a 3-day EMDR intensive in Calgary held on July 13th, 14th, and 15th this summer. So thank you, Dr. Sweeton, for taking the time out of your busy schedule to answer a few of my questions, and I look forward to working with you at the conference in Edmonton.
Thank you so much. I can't wait.
Okay, thanks, and bye for now. See you soon.